All right. So, actually, because this is one of the things we do. Say, so I take one med home about aneurysms, asymptomatic. They don't cause any symptoms until sure. Any questions? We're working at it. And with rupture, we die. So if we identify patients who have aneurysms before risk for rupture, fix them electively, we save lives, right? So we know most times we're improving symptoms. That's a good thing, but we're not saving lives unless it's acute. We treat claudication, we're making it better, but we're not making them live longer. This one's saving lives, making them live longer. That's so here's an example. 5-year-old male. He's got hypertension. He used to smoke. Screening things is back in 14, and he's having a 5-centimeter aneurysm. So his practitioner did the right thing. He got a CT angiogram, and he had a 5.5-centimeter aneurysm. If you have a, so here's what we're focusing on. And aneurysms are below the kidney arteries, so infrarenal. So you come here, the white is the flow lumen, that's the contrast. And you got thrombus around the aorta. I'm trying to all to here. Not to here. Yeah. Or normal aorta. And this is a normal aorta. You can see a better example, right? Here's the lumen. Here's that thrombus. So that's enough. You often get called by the primary care physician or people who aren't familiar with aneurysm and say, oh God, there's a blood clot in the aneurysm. There's always a clot in the aneurysm. It's a big dilated vessel, so you get a little slow eddy currents. You've all seen it, like if you watched a stream where it's flowing and then it gets wide and it's kind of stagnant around the edges. That patient causes that thrombus. Embolize. Aortic, abdominal aortic aneurysms don't tend to embolize, so it's okay. On the case. So we'll talk more in a second. This is how we fix the majority of aneurysms previously. Cases that I do under conscious sedation, so the patients are awake, talking, being a little fentanyl, or said. We test the vessels percutaneously, meaning we no longer need a surgeon to cut skin down to the vessel. And here's what's confusing to me until I started doing them. The schematic of an aneurysm, and we build the stent graft with patient's aorta. So the first piece we call the main body goes into this drawing is a little incorrect, but we place just under the renal arteries. You see here's the main body under the, and it's got a leg. So this leg to place it, so the main body is this leg that comes out in this iliac artery. The limb here just kind of hanging in space in the middle of the aneurysm. Then the other side with the graft, we this one and place it inside that one. That's the connection. So we build. What happened? Does that make sense? Here's that body connected, and make it longer. We can extend these pieces down further. And look like the case. The cases we do today, they get it done percutaneously. Stay over thoracic aneurysm. Three layers of the artery wall. An aneurysm is defined as 1.5 times. So, cell aorta infrared is usually 2 centimeters. So meters, that's 1.5 or 150%. 1 is 3 centimeters or more. It's an aneurysm. Okay. Can be symmetric or asymmetric, and the wall is weakened at the site of the aneurysm. Okay. So, kind of like blowing up a balloon or blow up. The bubble gets, you can see that wall getting thinner and thinner. It's pretty top, right? Same thing. This is a consequence of aging, atherosclerosis, infection, inflammation, degeneration. That's what we see in patients with other syndromes such as Ehlers-Danlos, Mark's. Those aneurysms don't tend to they're at risk of rupture. The peripheral aneurysms don't tend but embolize. So the plateal aneurysm, those patients present when they present with a problem with acute limb ischemia. This risk for developing aortic aneurysm. Aneurysms in different locations. Right? The ascending aorta, the descending aorta, those are both thoracic, abdominal aorta, aneurysms, popliteal aneurysms, visceral aneurysms, such as spleen aneurysms, cardiac aneurysms, are abdominal, and the vast majority are infrarenal, below the kidneys, the abdominal. So we've all seen the poster that we developed with Albert Einstein. Their virus. He died of aneurysm. So back really have a good means of treating it. So we actually had surgery for his aneurysm before a rupture. They wrapped it basically with cellophane. That did rupture. Al Conway Twitty, Roy Rogers, George C. Scott. So 5 aneurysms, 4 of them from the rupture. And that's pretty statistics today. If your aneurysm rupture, you have an 80 to 90% chance of mortality. Okay? And they're mostly men. It's more common in men and women. So if you at the red circle, that's how many people in the United States are at risk or estimated to have an aneurysm. And the dot is how many people are treated. So you can see proper screening. There's a lot of people out there there's lives that could be saved with proper screening. Okay? The inside is percent in 65 years of age. Aneurysm that's 5.5 centimeters, 50% you're dead. Right? Worse than right? 5-year, 50% mortality if it's untreated. 13th leading cause of sudden death in men over 60. That's common in influenza, is more common in men. In white men, there's some in place you should look at other places. So, in our protocol, as you come in with an abdominal aortic aneurysm, we get a CT chest at least once to make sure you don't have a thoracic aneurysm. We do a ultrasound, make sure you don't have popliteal artery aneurysms, right? Or vice versa, any of those. If you have a thoracic aneurysm, we get the abdominal popliteal, right? All 3 places. Yes, amazingly, in a lot of cardiology practice, you have that patient with a bicuspid aortic valve. Patients with aortic valve are more likely to have a thoracic aortic aneurysm. All patients have at least one CT angiogram in the chest. Thoracic aneurysm. Right? The 2 hand in hand. And the risk of rupture of a thoracic aneurysm if you have a bicuspid aortic valve is so the indication to fix it is a smaller diameter. because the risk rupture occurs earlier. Does that make sense? Excuse me? Aorta in a normal person, 5.5. And I think I have. But if you have a bicuspid aortic valve or Marfan syndrome, blah, 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 4.5. Okay. Question for, let's skip one. Okay. Right? The factors for developing the abdominal aortic aneurysm is smoking. For screening, but keep in mind that's why the indication is there for men 65 to 75 who have ever smoked. So if you smoked cigarettes or I think 20 years ago, that risk remains there. Aneurysms, you should be screened. You get more likely you are to have it. And the usual suspects for vascular disease, coronary disease, high cholesterol, goes with Marfan syndrome, COPD goes with steroid use. Okay, so tides ago, 5% in men over 6. Well, if you got let's focus here. Okay, so greater age to pass and can talk every day. 20%, 1 in 5. So if you've had a biopsy, you're over 60, and you're still smoking, there's a 1 in 5 chance you got it, right? So that, kind of, we're certainly treating all those patients appropriately in our practice. It's a cardiology practice, and we're missing a lot of these patients. So caught up with things, and you don't think about it, and you got, they got 1,000 complaints, and you're an hour and a half late to something like yesterday. You're not thinking it. Put you someone in your office, and in office, Julie Mang is very good. I mean, she's always thinking about that, but it's second nature. And, we put in that info. There's a flag now in F there, but it's there. Somewhere. But for rupture, is the size, right? We talked about that. The bigger it gets, the thinner wall, the more the boss. Hey, I can give you a lecture. Bye. So right. So if you look at the top diameter, so with the risk. So this is the way to think about this. Aneurysm gets bigger, the risk of rupture is going up, right? So repair is here. It's basically the risk of repairing aneurysms here. So it gets bigger, the risk is, so if your diameter is here, if your risk your diameter is here, you can see it's safer for touching rather than repairing. One gets riskier for rupture than repair. It's time to repair it. Does that make sense? So is it 5.5 centimeters? Right? 5 to 14 centimeters. So that's where the lines cross, right? So 1.5 centimeters or bigger, it's riskier to watch than it is to. You see, Jenna? Put it up there. Are concerned when they're growing quickly. So what's 0.5 centimeter in a year? So if screening, you're following that patient with an ultrasound, and at the time it's gone from 0.5 to 5. Well, it's still 0.5, but it's increased half a centimeter in a year's time. That's an inch to fix it. And in his smoke, have COPD or have increased risk. Family history, especially if they've ruptured. If first-degree relatives that have ruptured, the risk of rupture is higher. More eccentric, if you will, aneurysms, the ones that just kind of bulge out on one side, risk for rupture. Now, even though men have aneurysms more than women, if you're a woman, your risk of rupture is higher. Go back to that right here. This is women. The scrolling thing. Okay. Over 60, bypassing, continue to smoke. It's the same exact number. So, when it comes to aneurysms, see your rupture. If you put a plot on a graph, it's exponential, right? It goes up on a linear. So, forward risk is 5% of rupture time. You go up to 5 to 6, now it's up to close to 15%. So it's climbed. So the bigger it gets, the more like that it grows, and the risk of rupture increases exponentially. Make sense? Okay. So we're saying you don't feel anything until span leak or rupture. At that point, if ruptured, they die before they ever make it to the hospital. And then at the hospital, half of them die in the hospital. That's where you have 70 to 90% mortality. If your patient comes in today with a ruptured aneurysm and we operate on them, they're dying at 70%. Most of them are going to die. But if you find a patient with an aneurysm and treat them electively, meaning before they rupture, the procedures 2 to 7%. Right? So that identifying the patient, fixing them electively, see the difference we can make. Find the patient at risk, it's a non-invasive screening examination. Right. That all comers is more, yeah, but with vascular 1% or less. What study is they took patients, so the men over 65 who have ever smoked, and group is the brighter blue. They didn't follow those people. And this group obviously got screened with an ultrasound. In 5 years, the difference in mortality, right? So the much higher mortality, 2% versus the 5%. So the exam reduced mortality by 70% over 5 years. So that's exactly what we said. You find the patients at risk, and then you follow them until they need to be treated. You treat them electively, not emergently. And you oh, did we get in? No? Screening. Everyone's confused about this. So, what organizations, they had no organization ever agreed with another organization. Different guidelines. So these guidelines from the ACC, Society of Vascular Surgery, Society of Vascular Medicine and Biology, and basically agree that men over 60 should be screened. If you have screened, if you have a history of smoking, you should be screened. Not too much, but focus on what to pay for. So it's why this is such a big deal. But we never think about when we order stress tests every day or carotid ultrasound or echo and knows anything about the copay. But to aneurysm screening, that's like everyone's biggest concern is the patient's going to have to pay something. I don't know what copay would be. I don't know. Well, we'll get to that. So if you're a Medicare patient, Medicare will pay for a one-time screening exam, meaning it's free to the patient. If you're a man 75 years of age, who's ever, that's 5 packs, man or woman with a family. Okay? So that applies under Medicare for a free one. But then if Meredith comes in my office and on a Medicare patient, which is then I want to look for an aneurysm, I can't order that test. I can order anybody I want. Now, Meredith, whatever, it depends on what it says. Her copay, she'll be a copay, just like any other test. If I do a carotid ultrasound or an echo on her, she's responsible for it. Does that make sense? So, old man whose dad died of a ruptured aneurysm, and I think I feel something there. I will do an exam. You don't have to wait until the 65 hours. Make sense? You want the free exam, it's a Medicare patient who fits these criteria. There's not a confusion over the last couple of years. For CPT code, this is ordered differently. So if you want the one, you got to order it with that CPT code. You put it in diagnosis as you can, and they will get a copay. So what do we do? 3 centimeters. I told you less than 3 centimeters is technically an aneurysm. That's sure. If it's really need to do anything. If it's 3 to 4 centimeters, we do it once a year. We do it every 6 months. 5. Once it's 5 or bigger, I start talking to them about fixing. Okay? 5 in there, we really pull the trigger. So here's these laying this way. Because I should flip this. And this laying this way, and this figure. But sort of coming down here isn't there. All right? But there's just do. See the trend, right? The total number of aneurysms really hasn't changed over time. But the amount for surgery is going down, and the people who are going for endovascular aneurysm repair is going up. Now, the more people being fixed today with endovascular aneurysm repair, the more from repair continues to decrease. Meaning, it's not an inferior option. In fact, maybe it's a superior option. Okay? So, I'm a bottom line kind of guy, so I don't spend a lot of time going through all the trials, so we can just go down here. Endovascular repair is less time, so it's an hour to do this. Shorter hospitalization, less morbidity. The patients don't get as sick with the endovascular repair. Decreased short-term mortality. Okay? Yeah. Yeah. You're probably right. Yeah, if you get open repair, you've got an ileus, right? So you're in the hospital with an NG tube probably for a week for your valves to start working. The pain associated with the abdominal operation.
No, I even put a face. Yeah, I did.
Yep. I agree. So, a role for surgical aneurysm repair. there's certain people's anatomy that's not appropriate. If you're risk, we'll touch a little later. So let's say I did no endovascular aneurysm repair. I have to have an annual CT scan. Second, one-time operation, I'm probably done. Be a healthy guy, maybe surgery would be better for me. So good operative risk on the left-hand side. Those patients, you may want to consider moderate high-risk patients we're doing endovascular. And then preference is important. So I have people who come in who are 50 years of age and say, I want surgery, I want endovascular care. After risk and benefits, if they want to, I think that's appropriate. So benefits in green, risks in red. Opening surgical on the left, endovascular stents on the right. They've been doing it for 50 years. You exclude the aneurysm. There's no chance for sac growth at that site. That could grow above the repair, but they're durable, and you don't need the annual follow-up with CT scans. Minimally invasive is a lower morbidity, mortality, faster recovery, reduced blood loss. So, well, we talked about it. It's very safe for surgery, long procedure, high morbidity, mortality, slower recovery. Risk impotence, when you're operating in the pelvis there's a chance for them to have erectile dysfunction after. Endovascular repair. Something like that.
You didn't know.
Risk. Not everybody's a candidate for endovascular aneurysm repair, but as technology evolves, we do have photographs so we can treat more and more people. Anyway, long follow-ups. These patients come back every year and get a CT scan made.
Do you feel like you had a bad childhood?
We're going, all right? The other can go late, but you can't go on top. Sorry for the interruption. I want to load my case now. Yeah, scans every year that we're looking for endoleak, grad enlargement, so for aneurysm enlargement. Patients back for repeat procedures on occasion. Patients can develop endoleak, which we'll talk about, and there's something to fix those. We're not really going to talk.
Whatever you want, don't really yeah. Opposite.
Ready. There's this question. Here, endoleak. So this picture of a thoracic aneurysm. But the same thing, there's different types of endoleak. So one is happening at the attachment site. So maybe you can get a good zone is getting around into the sac. So the reason aneurysm works, what you're doing is you're sealing above, you're sealing below. So blood is no longer getting into the aneurysm sac. So if you were to stick a needle into the aneurysm sac and measure the pressure, it would be much lower than arterial pressure. So you've taken that pressure off the wall. So the aneurysm stops growing or sometimes even shrinks. Okay? So if you continue to leak, you continue to have pressurized blood flow into the sac, the pressure on the wall is just as high and grow. Okay? This is what most often is type 2 endoleak. And then a collateral vessel. Okay? So a little blood vessel that comes off the aorta, it's not just a straight tube where we repair it. There's little blood vessels that come off the spine. They can collateralize with other vessels. So once you seal the aneurysm, you can have reverse or retrograde flow come into the aneurysm sac. Now, the leak usually doesn't pressurize the sac to the extent that they're going to continue to grow and rupture. But so that's part of the reason we're doing that CT scan every year. They come back in a year, as we have right now, we're trying to figure out how to do it. He's got a leak, and his aneurysm sac has grown by 5 millimeters in the last year. So that's concerning, right? So if graph's in there, right now it's not doing anything. I got to puzzle and put the equipment in, get rid of the leak, get the pressure off it again. Sense? It's important to know about these, but the graphs, you never seen it happen. Graphs, you get kind of leaking through. It happens initially when you that goes away. And something's not really understood is endotension, which is can't really, but you continue to have sac enlarged. And if they're occurring, they need something done. I mean, in that case, you're probably going to convert to an open. So the patient can take the graft and do it there.
So all of these.
So after graft place, I'm back in 3 months and deal with the it does. I don't do it again in 6 months. I just go to once a year. And what aneurysm is not increasing in size, shrinking in size. And I see an endo leak. If I do, I'm watching. If it's stable, fine. If it's getting bigger, I got to do something. That's the endo leak. Oh. Let's hear a little about repair. This is for this is for everyone. So open aortic aneurysm repair, 5.5 centimeters. Okay. Line is growing over half centimeter. Ascending thoracic aortic aneurysm, 5 and 6. Descending, 6.5 to 7. So what is it higher for descending? It's not just a rupture is any different. It's just repair higher. So those lines don't cross until a higher. Makes sense? Almost one on all. Most of them thoracic, descending thoracic. Anyway, so patients with Marfan syndrome, Ehlers-Danlos, bicuspid aortic valve, they have problems with the media of the aorta, and they rupture, they dissect earlier, so their risk higher, so you can pull the trigger sooner, 4.5 centimeters. Helium is those occasionally, but 3.5 centimeters where I compare those. Palpitism 2.5 centimeters. Medicare for a one-time 16 screening aortic aneurysm in between 65 and 75 who have ever smoked. Men with aortic aneurysm, women with a family history, definitely all of them, right? It is true for ultrasound, follow-up ultrasound. No, it's less than 3. You won't have to do it between 3 and 4 annual. That's true. Between 4 and 4.5. True. Yeah, I got tricky about it. Good. That's physician preference. Yeah, rule. So, but my practice, I put them on aspirin Plavix for the first 3 months. Months if everything looks good. Stop the Plavix if they have their indication. Some aspirin. Yeah. Other questions? Face closed there. Right here. So, yeah, you guys get to tell me what you want to. Acute leukemia, those are people that come in with a cold leg, what to do. I think that's kind of like subclavian disease. Filtration, that's IVC filters. That's carotid artery stenting. Eugenic central venous occlusion, those are patients who have, terminate DV pacemakers. And we cut them too, really, last week. So, acute. Maybe we get quicker, maybe we get through that crowd. All right. So this is a paper, a review Greg and I wrote 2 years ago. So the one with the history of hypertension, atrial fibrillation. I don't have any questions. 1 month ago, atrial fibrillation, no anticoagulation. It'll stop because of the G bleed. She should get a Watchman, huh? Presented. So they are abrupt onset leg discomfort. So all right on my leg. The pulses are ABIs. If you angiogram, see this right here? The level right there. Right? Atrial fibrillation. What happens is the top of the atria kind of quivers. That's what fibrillate means. Fibrillate's like a can of worms. So the left atrial appendage is a hollow pouching of the left atrium. It's about the size of my thumb, but it's hollow inside. So when you have quivering, blood just stagnates there and you get a blood clot. We know the fact that most people with AFib who have stroke or peripheral embolism comes from the left atrial appendage. So here you got this woman with atrial fibrillation. She stopped and thrombus, and for what reason it got damage, and luckily it went to her leg and not to her brain. Okay? This is embolic, right? This is the embolus. So down here, and what you see is it's an abrupt cutoff. You can see the thrombus. You don't see a lot of collateral vessels. There's no vessels down here. Okay, as opposed to a patient who has thrombotic anemia. So this patient, you can see it in here. Lots of collateral. So it didn't embolize. This one probably slowly, more akin to anemia, developed a stenosis that throws them one day. So this patient kind of had time to develop collateral. So 6-year-old female, we know she's got PAD because she's got stents. 4 days after acute onset of right leg pain. So she kind of was able to get by for a couple days before she said something's wrong. Rather than no, I mean, it hurts so bad she has to get in there right away. Collateral vessels. Comfort improved, collateral vessels, but continue pain. Okay, so acute limb ischemia is the abrupt interruption of arterial flow to an extremity. So down limb ischemia, so you get rest pain. If it's not treated, you develop ulcerations, gangrene, and you lose the leg. If you get the blood flow back to the leg, you can save the leg. If it's still too long, you get lost, and then it's just not the limb. There's systemic complications from it. People die. So that if you have acute limb ischemia, 1/3 are going to lose part of the leg. 1/5 or 20% are going to die. So it's kind of like a heart attack in the leg. Within the first 12 hours, it's associated. Not to be as quick. It's not 2 hours like an MI, but 12 hours. Decreased mortality rate if you treat. Limb salvage rate is pretty high. Delay of 12 hours, you got 30% mortality, 80% limb, as opposed to 93% limb salvage rate. I think these, so that's kind of the pain leg. Full leg, pulseness, paresthesia. So this develops over time, and this is due to ischemia of the nerves. So first light touch is affected, then vibration, proprioception. Much later, deep pain. So, they can't leg. First things we do, we want to, this patient's got a cold leg without pulses. We want to kind of see their neurofunction is in that limb. Worse is the lower one. It becomes so bad that it's a limb. The more distal muscles first, the more peripheral the nerve endings, the more at risk they are. Most are thrombotic, so most of them are the patients with a chronic peripheral arterial disease. 10% are patients with AFib, but you always want to think about that patient with a cold leg. They have AFib. Embolic, it's almost always AFib. Okay? 80% of emboli are cardiac and etiology. I put here an MI, so those are the patients who've had the anterior side developed the left. So fusions occur at the site of pre-existing peripheral arterial. So maybe the patient had a stent graft in their leg and they developed stenosis on the stent graft. Unlanded healthy arteries have collaterals. So sometimes we'll see it at the femoral artery or popliteal artery. Thrombotic arterial bypass grafts. So bypass grafts, so thin pop graft, they're pretty good for 5 years. After that, they start to regenerate. They can develop thrombosis. So, it's a big get a fem pop and then just disappear and never get the screening. But 5 years, they should be getting at least annual duplex of that whole graft. After that, I start doing it every 6 months. Because you want to catch stenosis before it's thrombosis in the whole leg. Infrequent, so vegetation embolizes, air embolism, maybe during childbirth, trauma, dissection. That's when patients have an acute DVT and they have such intense swelling of the leg, there's such pressure in the leg, they actually include the arterial circulation. We don't see often, but it's a life-threatening consequence of DVT. Patient who has that DVT, bless you, an egg, and they don't have any arterial pulses, they're starting to have sensory deficit. That's an emergency. Proximal aneurysms, so we just talked about this. So aneurysms. So you get acute limb ischemia happens from a popliteal aneurysm. The clot in the aneurysm is embolized into the popliteal vessel. Other things. Wow. So with embolic, right? The embolus is coming from the heart somewhere, and then it gets stuck in bifurcation, and then it obstructs flow distance. where we beat this to death, huh? Thrombosis to the site of a previous stent, previous graft, or previous perforation. So it's kind of lodging at the iliac bifurcation. You see that, but mostly it's the leg. Okay, so include the aorta at the level of the iliac bifurcation. The iliac arteries are then going to the femoral artery. So you got leg, you might have hip and buttock pain. Yeah. So get the history, and we kind of talked about this in the first couple slides: embolic versus thrombotic. For more gradual onset, prior event like an MI versus no cardiac event, no PAD and embolic versus a history of PAD. These are fast, but these are clues, right? So we let the patient ER help them figure out what I think this is. Vascular surgery, arrhythmia, so we're always getting the EKG looking at it'd be severe symptoms with embolic. The old model, almost cadaveric leg versus cool. They may have normal limb on the other side, whereas robotics may have signs of perforation, immense pulses. It's pretty clear cut, so you have abrupt cessation above a certain level. Pardon me. Cessation, let's say at the femoral artery or the iliac artery, so it's pretty clearly demarcated. There's no flow beyond that. With thrombotic, remember they've had time to include. They have collateral flow, so maybe like I can't really tell where the level. We saw look at all the collaterals here versus really much collaterals here. You can clearly see an embolus. You kind of got that little meniscus line where it's you got the collateral. Or excuse me, the embolus that's included in. All right. So this means of classifying the leg is it type viable? So there's no immediate threat for losing a leg. They haven't lost any sensation. They still move their legs. You can hear a pulse. You still have a pulse. You threaten. Well, lose some sensation, right? You know, it's more profound than just maybe at the tips of their toes. Maybe they can't move their leg. Okay, I can't find any pulse anywhere. Or is the patients that they have that cadaveric leg, you know, they can't move the leg, they can't feel anything. But this, it's a, you know, there's no arterial pulses, there's no venous flow. This coming. The symptoms can with the level of their previous collaterals, and then how long has it fluid? So occluded vessel, there's sluggish flow beyond it. The thrombus is going to start to progress. There's going to be more vessels involved. I'm like, God. So, you know, the initial evaluation we've talked about that. You think they have acute limb ischemia, they all are going to get anticoagulated. Then we're going to kind of look at how bad is this leg. Well, number one, all the way to the left, we got that liable. Do we think intervene acutely? If we're going to do it, we need an imaging study. Not always an angiogram. Maybe it's a CT angiogram. Maybe it's an MRI. If you don't think it's early, maybe we're going to treat for like limb ischemia. Maybe these patients can be treated medically or electively. Type 2, they're immediately threatened. they're going to go and get an angiogram or some sort of imaging study pretty quickly, CA, MRI that night. And then we're going to select appropriate therapy. So this is the one time in vascular disease you're probably going to hear me say that most of you should get surgical treatment. Okay? And what for the embolic acute limb ischemia? So those patients that AFib and that embolus has gone to the leg. The embolus has probably been cooking in the heart for a while. These things tend to be these rubbery, kind of where you balloon them, but they spring right back. Of course, they just go further down the artery. So what are, let's say it's at the femoral artery, they're going to cut down and they slowly the catheter above it, which is a little catheter, they inflate a balloon, and they pull it out, and the clot pops out. They repair it. Good. This is a pretty easy artery to get to. Case is so. Doesn't mean I don't want to admit these patients. We don't want to take care of these patients. We do. We want to get the proper workup going. But if I get a embolic conclusion, I'm going to call surgeon and say, hey, this guy needs an that's what surgical treatment. What was that? Oh, he's not surgeon. That's all right. So Doctor is two guys. Those two are both. Dr. Hodge is a vascular surgeon at SIU. That was a guy to deal with. Dr. Barker. What do you? So Dr. Barker is, you know, the running joke with Dr. Barker is if you want to call someone else, if you want an insult, you call her. Has she? Well, good. And those are surgeons. This is kind of what we went through. All right, so this is what you're going to start to see, right? Three loss. You know, they can't move the leg. You don't have signaler, and you're starting to lose venous signals. You know, you get rigor, marbling, and muscles. I mean, even you wouldn't save this leg, but even if you were, you'd have just a dead leg. So, nation. Take that limb we just looked at and try and fix it. Well, you are going to end up with a functional limb that is extremely low. You made a worse scenario with a unique limb. Our patients, they're starting to develop swelling. Swelling up in the thigh is not a big deal. Down below the knee, you have 4 compartments. Okay, so then sub-segments of the leg that are encapsulated by fascia, and that fascia does not expand. So you start to get swelling in there, and you have is high pressure and compression of the nerves, the arteries, and geotomy. Meaning the surgeon go in there and open up those compartments to relieve the pressure. You know, if the skin looks good, there's likely underneath underlying muscle necrosis. Slim, develop contractures. Release bioactive substances from that ischemic limb that cause problems. renal failure. So that list's not salvageable. You don't try and salvage. It's better for the patient just to remove. Reperfusion syndrome, you release leukocytes, white cells, platelets, inflammatory mediators, the goals, myopotassium, lactate, all this stuff contributes to rhabdomyolysis and renal failure, result of renal failure, and death. So that dead leg mortality is pretty high, as high as 40%. Things get the leg off and start thinking about the patient's life, not their leg. Yeah. So usually a few weeks. So we see that pretty commonly in patients we do electively for included SFA, right? They'll call us a couple days later. It's like, man, my leg red and swollen, and with the ER, and they didn't find the DVT. With syndrome. So what do you have in the included vessel? Okay. So the way it compensates is it maximally dilates all the downstream vessels, right? Get as much perfusion as possible to the end organ, which is the muscles. Then you open up the floodgates, right? And have all that flow in those maximally dilated vessels, you start to get leaky capillaries. So you get kind of erythema, and it takes a few weeks for the goals and the beats return to kind of reset, if you will, and to cover that. So weeks of conservative therapy. Embolectomy, this catheter, so it's through the thrust in the undeflated. Deflate the balloon and pull it back. You bring out the clot. We do. So this is very good for a version of a bypass graft. So FemPop graft is included. Catheter. But imagine there's one catheter running through here. What this is, little ultrasonic transducers catheter, and then the catheter is also like a soaker hose in your guard. So in most vessel, you would, and the TPA penetrate into the clot. It also helps to kind of unwrap the fiber. And it's pretty in an artery. I mean, you put it in the morning, you come back in the evening. You just see the stenosis because the problem's dead, and you're done. Well, this is a catheter to use, but what you do is you put it through the clot, and you can inflate proximally and distally, and put T between, kind of in here, and the motor, you'd activate it. And this would literally spin like an egg beater for like 5 minutes. And then you slide it. There you go. Margaret. Quite a bit. This is process, so you probably heard of the angiojet catheter. So here's the shower head part of it. That's Abraham Lincoln's face on a penny, right? It works. It's got these very high saline that are squirted. This is the tip of the catheter over here. So they're squirted backwards, and that creates effects. So, the high velocity creates a zone of low pressure around the high velocity. So like a little vacuum. So the jet there creates a vacuum here, and you can suck the clot into it. It works pretty well. Yeah. We turn off the suck part of it, if you will, and PA through this. So run it through there and put T in the clot, and then we sit there for 5 minutes and let it marinate. Then we go put the suction portion on and just try and suck. this is kind of the with triple A's. You know, over repair and trailing off here, endovascular means more frequently in limb rates or amputations. Catheter-directed thrombolysis over surgery may be underrepresented due to subsequent disease management. Surgery has decreased from 34.5% to 26% rate. Catheter-lysis, so that's what we do in the cath lab, has increased from 30%. The amputation has decreased. So the slide I showed you for AAA, even though we're doing more things, endovascular means the outcomes are better. Does that make sense? Definitely here. And I don't think this play, but this is that funny catheter, the egg beater catheter I told you, the balloon here, and if it plays, wire spinning around. Catheter, the one with his head, and this is a little filter I put down there, just a cat might embolize. I send anything down, you might catch it before, but it's too far. So this is at the beginning with the AFib. So this is the kind of result. You see a pretty normal looking vessel. The patient with the thrombus, and he uses all the clot. Well, there's a stenosis there, and you remember this patient, you can sort of see the stems there. What's this? Yep. Okay, so acute vascular emergency. First thing, heparin. Manages catheter percutaneous mechanical thrombectomy, taking flab, or surgical thrombectomy. Is that patient with AFib? It's probably depending on the severity of ischemia. And the so cath lab is viable for some patients. And then the patients, there's a lot of metabolic abnormalities that occur afterwards that patients need to be monitored for and treated. Good. Carotids. So you really got north. Oh, question. 75% asymptomatic carotid artery stenosis should be treated with endarterectomy, sting, therapy. DCP, but it's actually. So, yeah, like, this, and this is the point of the CREST study, that, and I'll show this real quickly. Asymptomatic carotid artery disease, we're really sure, is this to treat them medically, stroke or TI, or to fix them, standard. We need to be fixed. Does that make sense? Let's see if I can show that. And then, yeah, that's nice. Ocean's frozen. Those are my two boys. So, the higher the degree of the more likely you are to stroke, right? That's what this shows. 1993, we did a trial where we took those patients and we did endarterectomy, or we treated them medically, and who had endarterectomy after subsequent strokes. Okay, everybody with 70% or higher carotid stenosis has to be fixed. Stents. So we compared carotid stents to surgery, and they're equivalent. Okay. So we thought you had to fix the artery, the road, tooth, probably just as good as surgery. Maybe stents looked a little bit better. We were one of the high enrollers in this trial. There is, I don't see money credit. But basically, these trials show that stents, probably just as surgery, really showed, and this is statistically not inferior. They're not worse. Not worse. So, okay. These are the guidelines. So, symptomatic patients, everyone should be treated if they have significant stenosis. Definitely, and they've had a symptom. We can do an endarterectomy, you can do a stent. And they're symptomatic and really don't have any other reason why they had a stroke or a TIA. You probably fix that carotid. But the evidence is strong, so that's a class 1 indication, right? For 8 patients, class 2, maybe it's reasonable to do an endarterectomy or stent in patients who have that's it. So the vast majority of the entire country is covered by ice, right? Like 10% of it. Here is we're camping on the seas of the ocean and coming down the ocean, traveling with some Eskimos. Because they have those big sleds you saw on that other slide. They put them together side by side. I told them they're 10 till and they're ready. And they pop the tent up over it, so the sleds act as the floor for the tent. Yeah, pretty cool. So remember I told you in '93 it looked like fixing was better than treating medically, but over 20 years we've become aggressive, so we're more aggressive treating high blood pressure. You can see we're better at doing it, and their pressures come down, and we're aggressive at treating. So it's still true that medical is something, well, we don't know because medical therapy has changed in that time. And that's the whole basis behind the crowd. So these boys, they were this guy Peter, sleep, and they were supposed to be home, but Peter, before this little town he lived in, went up down this caribou coat, and they made Joseph wear it. Because, what? They had one for Jacob too, but the arms were too long, and the fur was his face. But he's a kid. This is a couple of years ago. Because his arm, he was trying to wipe it with more fur, and he was so angry. Finally, Peter gave in, and I think it's sitting there. But it's a cancer polar bear. It's kind of a message when you go from a boy to being a man, you get your polar bears, and sometimes the color here is seal, or the jacket seal, and the color is usually caribou. That's the most interesting part. We'll just get to those slides. rolling in that now. Okay, and comparing method to fixing. So decide how you want to fix. So, meaning we flip a coin, it comes up one way, they get medical therapy, comes up the other way, they get fixed. Going into the trial, you can decide if it comes up, I want a stent or a direct. That makes sense. So, physician has a choice. 50% what's better, medical therapy, carotid therapy, or carotid stent? So who's over 70%? Okay, by duplex, we can do it by gram, we can do it by CT. This is an independent parallel trial. So you can pick, I want to be in the stent trial, and my stent versus medicine, or I want to be in the surgery trial, and artery medication. We know they're at higher risk for stent. So the older you get, the risk goes up with stent. If you're 70 or less, you can do better with a stent. If you're older than 70, you may do better with surgery. So here's Jesse in this big. What happens with those glaciers that I showed you? They, it's solid ice, but they're flowing slowly, right? Like a stream. See, and they calve, meaning some of them just break off into the ocean. Well, when it's all frozen, it's stuck in the ice, and then in summer, they float out, and that's an iceberg, right? And in the winter, it freezes in place. So he is kind of laying on this hollowed out iceberg here. So all the way, it took us 3 days to get to this remote village in Greenland to start shipping. And here's a trip with us, folks. Yeah, this is a fan hitch. So you can dog sledding in different parts of the world, but in Greenland, the way they do it is they let the dogs kind of fan out, and they come next to each other. And people who are guiding the sled, they have this whip, and it's 30 feet long, and they'll put above the dog's head to the left, and that'll make him turn right or snap to the right. Left. They get him right in the tuchus, and it's something there. Did I pull? Turned on by my well, because of anatomical considerations, they had neck radiation prior aneurysms. They got a trachea. Those patients should be prostate. They're really tortuous. You can see it's tortuous, rotted. Imagine if I put a stent in there, that's not going to look good afterwards. It's going to straighten up and bends somewhere. To get there, we got to come through the aortic arch. We got to come up, over. So if there's a right carotid stenosis, you can see, I push up and over. The more I push it, it's going to want to go down here. It's not going to want to do that second band and get there. So these are tough to do. Like put them at risk for stroke. Maybe it's better to just do it endorectomy. So certain patients have maybe shouldn't. Those are called street signs. So the risk of stroke goes up the higher the system until you get to about 99%, and 100 it drops down to 0. So there's no flow. There's no from carotid is different than ischemia in the heart. So it's blood flow. Well, it is, but it's not low blood flow or lack of blood flow caused by the stenosis that causes stroke. It's of the plaque or a thrombus that forms that then embolizes up to the brain to cause stroke. So food slowly over time gets to 100%. There's no flow. That's not a stress. Think about that. You don't open up a carotid artery. And this really do this. This is what they do. They open the artery. You can peel out that lining with the stitches, and they leave that kind of opening there, and then put a patch on it. So if you go to an angiogram afterwards, it looks like a leak vessel. And then we have embolic filters. It's called MOMO, which we kind of stop all blood flow while we do the intervention and suck all the blood out the end. There's Jacob. Huh? Yeah, he's the iceberg. Huge pieces of ice. It's like the National Geographic. You know, all getting intensive therapy. They're all on aspirin. They're all getting high-dose statins. They're getting antiplatelet therapy. They're getting maximal therapy. There's so these people in the trial, it's really good for them. They're really getting, obviously, they're getting maximal medical therapy, cholesterol, their diabetes, they're going to get them to stop smoking, their exercise. They have this intervention management company, so they have kind of like a life paid for. So these people, they have asked to them 4 hours a day where they can call them with medical questions. These people are calling them, encouraging them to stop smoking, encouraging them to take their medications, exercise, really doing they can maximize their medical therapy. They get a free medical each of the classes, so paid for the trial. Diuretics free, their ACE inhibitors free, beta blockers free. I think they get stat. He's nice as he looks there. He's a Trump here. That's Joe. So the crest is asymptomatic. We'll have the registry where refuse to randomize. They say, I just want a stent. They can go to the registry. We can treat symptomatic, high risk, and low risk. So anybody. So if your patient wants to be in a trial, or maybe they're a symptomatic patient, we can treat them. Hospital first. Okay. So in stenosis, you don't have to think about it. Any one of them, they can be treated. So we can, just say, if you have to send it to Dr. Gill or Vishwami or me, we'd be happy to see the patients. All right. Any greater than 18, they have 170% stenosis, and they're in the trial. That's it. So this one. Watch our peaks. Right. Okay. Good. Thank you.
I didn't still hear me. Not a patient.
Okay.